Welcome back. I'm Dr. Ribinik, the Neurology Clerkship Director at Rutgers Robert Wood Johnson Medical School. Today, let's talk about intracerebral hemorrhage. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. I have no relevant financial conflicts to disclose. The case was modified for teaching purposes. We have a tale of patient MP, a 59-year-old man with uncontrolled hypertension even despite his multiple antihypertensive medications. He was found by his partner on the kitchen floor with acute left-sided weakness, headache, and lethargy after fall. He was neurologically normal before he went into the kitchen for a moment when the partner heard a thud and rushed in to check on him. The partner admits to patient having binge alcohol consumption on the weekends. There are no previous such episodes, febrile illness, or significant weight loss, and our patient has unremarkable family history. Because of his partner's efforts, he presented to the emergency department within 1 hour after last seen at baseline, and in ED he vomited twice. You're examining him. Blood pressure is elevated at 179/65 millimeters of mercury, but the rest of the vitals are stable. Our patient is protecting his airway. He's lethargic but responds to voice by opening his eyes and attending to you. When awake, he's oriented to place, person, and time. There's no aphasia or neglect, but he does slur his words significantly, and you notice a left upper motor neuron pattern facial weakness. Lower face is involved and the forehead is spared. On the body, there is flaccid, meaning low tone, dense left-sided hemiparesis. He has no anti-gravity effort on that side at all. Our patient also reports mild sensory deficits on the left. First things first, what are the possible localizations of this lesion? Here's an oversimplification of the motor pathways. Our patient has a left-sided hemiparesis and facial paresis, and that's pictured here in blue. The possible sites of lesions are pictured in pink. First, you ask yourself, what is the lowest level of the motor pathway at which a lesion can affect the face? Well, the face is controlled by the 7th cranial nerve, with cell bodies in the 7th nucleus in the posterolateral pons. So the lesion cannot be below the facial nucleus, otherwise the face would be spared. The possibilities are the pons, midbrain, internal capsule, corona radiata, or the frontal lobe, 5 locations. That's way too many for us to consider. We want to narrow it down. But how? Well, what other deficit does our patient have? Our patient has sensory loss on the left side, pictured here in purple. The motor and sensory pathways intersect in the thalamocapsular region. So we're dealing with a lesion affecting the thalamus and the internal capsule. Next, for our 59-year-old hypertensive man presenting with acute headache, lethargy, left sensory motor deficits due to presumed thalamocapsular lesion, what is the pathological differential diagnosis? Acute focal neurologic deficit. I'm thinking the same as you. Intracerebral hemorrhage. Acute ischemic stroke. Our patient is lethargic, so perhaps the basilar artery is involved, causing reticular activating system impairment. A seizure with postictal thoughts paralysis, and maybe a brain mass, neoplastic or infectious. Well, let me ask you this. Why did we all instinctively put intracerebral hemorrhage at the top of our differential list? Hemorrhages start acutely, yes, but they expand rapidly, creating mass effect over minutes. Patient develops symptoms of mass effect, headache, lethargy, confusion. So, acute focal neurological deficit, ischemic stroke is most likely. Acute focal neurological deficit with headache, lethargy, confusion, we are more concerned about hemorrhage. So, riddle me this. Which is most suggestive of acute intracranial hemorrhage? Severe hypertension, vomiting and headache, intraparenchymal or inside the brain hyperdensity on the head CT scan, or gut feeling? Did you say vomiting and headache? Let's see if you're right. No, I'm sorry. It's best to learn this painful lesson now. No matter how much the clinical picture may be suggestive of hemorrhage, you can only be sure after a non-contrast head CT shows a hyperdensity corresponding to a hematoma, like the one pictured here. Our patient presented within 1 hour from symptom onset. His airway, breathing, and circulation are stable for the moment, and we decided that we're concerned about a right thalammocapsular hemorrhage. So, how do we confirm our suspicion? Non-contrast head CT. You're learning. Let me briefly orient you. This is a non-contrast head CT, axial cut. The patient is lying in front of you feet first and facing the top of the slide, and the patient's left is on your right. This cut is at the level of basal ganglia, head of caudate, thalamus, internal capsule, lentiform nucleus. What's the abnormality? Right, there's a hyperdensity in the right lentiform nucleus, putamen, corresponding to an acute intracerebral hemorrhage. There's also a hypodensity surrounding the hematoma, which corresponds to cerebral edema caused by this blood. Notice that both hemorrhage and edema are affecting the internal capsule and exerting mass effect on the thalamus, hence the sensory-motor symptoms. So the non-contrast head CT showed acute right basal ganglia intraparenchymal hemorrhage. Now that we confirm the hemorrhage, what is the next best step in the management? What is the primary goal of hemorrhagic stroke management? Forget about everything else. This is the most important thing right now.
Prevent expansion.
Preventing expansion. A burst vessel may continue to bleed, especially driven by elevated blood pressure or a clotting problem. To
prevent expansion,
we use two strategies. Aggressive blood pressure control to a systolic blood pressure goal of 140 to 160, that goal is debatable by the way, and correction of a coagulopathy or clotting disorder when it's present. Once that's taken care of, the next goal becomes prevention of secondary injury. Secondary injury from mass effect, edema, hemorrhages may cause significant increases in intracranial pressure, which may require surgical evacuation. In this case, thankfully, our patient is not herniating, so emergent surgery is not needed. Next, homeostasis is essential. Treatment of fever and hyperglycemia decreases the chance of a worse outcome. As you can imagine, our patient is at high risk for deterioration, and this care happens in the intensive care unit. But once secondary injury has been mitigated, the final goal becomes preventing recurrence. Actually doing the workup to determine the exact mechanism of hemorrhage, of course to address it with appropriate therapy. So, in our 59-year-old man with hypertension who developed acute right basal ganglia hemorrhage, blood pressure was aggressively controlled and is currently at 137/68. Coagulation labs and platelets were normal, so we're not concerned about a coagulopathy. Our patient remains neurologically and radiographically stable. We actually repeated a stability head CT at 24 hours after the initial scan to document that the bleed did not expand. Well, all's well that ends well, but how do we actually prevent future hemorrhages in our patient? To understand that, we need to briefly discuss causes of hemorrhage and diagnostic studies. When it comes to hemorrhagic stroke, we're essentially dealing with vessel or blood-brain barrier integrity problem or decreased clotting potential. Impaired blood-brain barrier. Well, that actually happens in the setting of an invasive tumor, like the high-grade glioma that's pictured here on a contrast-enhanced T1 MRI. Vessel wall injury and rupture can of course cause bleeding. Vascular malformations can also rupture, because an artery, a high-pressure system, is connected directly to a vein, a low-pressure system, without an intervening capillary network to equalize the pressure between the two. A vein doesn't have the muscular walls needed to contain that arterial pressure. A break in blood-brain barrier can be imaged with MRI of the brain with gadolinium. Gadolinium typically does not cross the blood-brain barrier unless it's leaky. Vasculature can be imaged with non-invasive studies like head MR angiogram or CT angiogram. And assessing for coagulopathy involves simple blood tests. That's all nice and simplistic, but we need to add one more layer of complexity. Location of the hemorrhage in the brain and the type of hemorrhage actually matters. Hemorrhagic strokes are either intracerebral, or more precisely intraparenchymal, inside the brain parenchyma. These can be located in the deep structures, like basal ganglia, or superficial, like the right frontal lobe pictured here. Of course, sometimes there's spillover of blood into the ventricles, so-called intraventricular hemorrhage. Hemorrhages can also be outside of the brain in the subarachnoid space, subarachnoid hemorrhage. By the way, you probably know two other types of hemorrhages, epidural and subdural. Those are outside of the brain, typically traumatic, and are usually not considered hemorrhagic stroke. So let's leave them out of the discussion. Where was I? Oh yes, intracerebral hemorrhage. We mentioned two types, deep and lobar. There's also such a thing as a hemorrhagic transformation of ischemic stroke. A patient suffering with significant ischemic stroke will have necrotic tissue in the brain that can bleed, like a brain bruise. This is a common complication of ischemic stroke, but once again, this does not behave the same way a primary hemorrhage does. It doesn't expand quite as rapidly. Deep hemorrhages are usually caused by diseased small vessels that are damaged by vascular risk factors. Hypertension is such an important risk factor here that these hemorrhages are actually referred to as hypertensive. Lobar hemorrhages may have many causes: vessel wall injury or vasculopathy, vascular malformation, impaired blood-brain barrier with a neoplasm, and decreased clotting potential or coagulopathy. Nice and easy distinction, isn't it? But about 10% of deep hemorrhages also end up having multiple causes. Bottom line, you cannot be certain about the mechanism of the bleed until you complete the workup. Let's delve into some of these causes in more detail. Who gets deep hemorrhages? Well, patients with vascular risk factors, especially those who are older and have hypertension. These hemorrhages are caused by the rupture of small penetrating arterioles, like lenticular striates off the middle cerebral artery that are pictured here, with the illustration of a typical bleed. But don't forget that these small perforators also exist in the thalamus, cerebellum, and the pons. And speaking of the pons, here's a gross pathology example of a small vessel left pontine hemorrhage. To orient you, this is an axial slice with the patient facing the top of the slide and the patient's left on your right. The fourth ventricle is also filled with blood. And the last image on the right is a head CT example of an acute right thalamic hemorrhage with intraventricular extension, again caused by small vessel rupture. And now, some examples of pathologies causing lobar hemorrhage. Another name for vasculopathy is angiopathy, and the most common angiopathy in older adults is cerebral amyloid angiopathy, or CAA. This disorder occurs in elderly with dementia, and the hallmark is multiple lobar and sometimes deep microhemorrhages on MRI, specifically on gradient recalled echo sequence, or GRE, which is tuned to show blood byproducts as dark signals. This is an angiopathy, so vessels are weak and keep rupturing, creating these microhemorrhages. And why are the vessels so weak? Well, the answer is right in the name of this disease. The same amyloid that can cause Alzheimer's dementia deposits in leptomeningeal and cortical arterioles. Here's the beast itself, set ablaze with Congo red stain. As you can imagine, such pathology can only be obtained by tissue biopsy, but biopsying the brain of an old person with dementia is just cruel and unusual punishment. So biopsy is more of an exception than the rule. A characteristic clinical history and MRI should be enough for diagnosis. Next, arteriovenous malformation. As I mentioned before, AVM is a direct connection between cerebral arteries and veins, or venous sinuses. The arterial system feeds blood flow at high pressure, and without intervening capillary network, the low-pressure venous system feels the strain and can rupture. Now, the risk of rupture really depends on the size of the AVM, its location. A rupture in the eloquent cortex, like the one responsible for language, would be especially devastating, and the type of venous drainage. A small AVM pictured here may never rupture, and a significant number of these are discovered incidentally. The same cannot be said for this large one. If it bleeds, it may cause significant focal neurologic deficits and seizures. The final cause I will illustrate is malignancy. As we mentioned before, neoplasms in the brain can hemorrhage. We are of course talking about metastatic disease in a patient with known malignancy or primary brain neoplasms, such as high-grade glioma. Here are two examples. These are axial CT slices from two different patients, and I sound like a broken record at this point. Both patients are facing the top of the slide, with the patient's left on your right. Neurological deficits, of course, depend on the brain locations affected. The patient on the left has a right frontal hemorrhagic glioma and presented with memory loss and cognitive slowing. The patient on the right with a left occipital melanoma metastasis presented with right visual field cut. The imaging looks very similar, doesn't it? So how did I know that the patient on the left has a glioblastoma and the patient on the right has metastatic melanoma? Well, these masses were resected and the diagnosis was based on pathological evaluation of tissue. So we discussed several categories of intraparenchymal hemorrhage, but we didn't talk much about subarachnoid hemorrhage since it wasn't relevant to our case. But in any event, this begs the question, which hemorrhagic stroke mechanism is most dangerous? I'm referring to the risk of hemorrhage recurrence. So I'd like to illustrate that risk of hemorrhagic recurrence with cats. Small vessel diseases like a lynx, dangerous but with relatively small risk of recurrence. Cheetah is a lobar hemorrhage, and lobar hemorrhages overall carry a much higher risk of recurrence. Because the risk is so high, cerebral amyloid angiopathy patients, for example, are often forbidden from taking any blood thinners, and ruptured AVMs often need to be surgically fixed. But the lion here is aneurysmal subarachnoid hemorrhage. Highest rate of rebleeding and high mortality. Very dangerous. Okay, theory's nice, but what about our patient MP? The 59-year-old man with hypertension who developed acute right basal ganglia hemorrhage. Last we left our patient, blood pressure was controlled, coagulopathy was not an issue, and he remained stable. What is the mechanism of our patient's hemorrhagic stroke? Well, hopefully you've been paying attention, so you think to yourself, "Self? We have a patient with known hypertension and a deep bleed. Seems like an open and shut case of small vessel disease if you ask me." Not so fast. Have you reviewed the vessel study and the MRI? Here's the CT angiogram. This view is called the coronal maximal intensity projection, where the patient is looking at you and the patient's left is on your right. The hematoma is here. What is this strange branch of the middle cerebral artery terminating at the edge of the bleed? So, MRI of the brain with gadolinium showed no evidence of neoplasm or microhemorrhages that would raise concern for cerebral amyloid angiopathy. CT angiogram, on the other hand, was concerning for a vascular malformation. So, conventional invasive cerebral angiogram was done to investigate. By the way, cerebral angiogram is the gold standard vascular study, but it's also the most invasive. Patient's vasculature has been reconstructed in 3D. That aberrant branch of the MCA ends in a tangle of vessels that then drains into the straight sinus. This is an arteriovenous malformation, AVM. Surprise, surprise! So our patient clearly did not read the proverbial book, and his deep hemorrhage ended up being caused by an AVM. This case really underscores the importance of systematic diagnostic workup, even in cases that may seem to you obvious and straightforward. So in conclusion, we discussed the case of a 59-year-old man who developed left sensory motor deficits because of an acute right basal ganglia deep hemorrhage, secondary to a ruptured arteriovenous malformation. He actually underwent an embolization or occlusion of the vessels feeding this AVM, and thankfully did very well. So what did we learn for today? Patients with intracerebral hemorrhage, just like ischemic strokes, can present with focal neurological deficits. But hemorrhages create mass effect early on, and can present with clinical signs and symptoms of increased intracranial pressure, headache, lethargy, confusion. The primary goal of acute intracerebral hemorrhage management is to
prevent expansion,
which means controlling blood pressure and reversing coagulopathy. After acute treatment, identifying the cause of hemorrhage, small vessel disease, vasculopathy, vascular malformation, malignancy, coagulopathy, is very necessary to select the proper prevention therapy. Ruptured aneurysm, causing subarachnoid hemorrhage, has the highest risk of rebleeding, followed by causes of lobar hemorrhage. And finally, speaking of identifying the cause of hemorrhage, which of the following is not necessary in the workup of intracranial hemorrhage? Carotid ultrasound, blood pressure measurements, imaging of intracranial vasculature, or MRI of the brain with contrast. Did you say carotid ultrasound? You're right, of course. Carotid ultrasound images carotid artery in the neck, which has nothing to do with brain vessel rupture. By the way, if you're still trying to keep these vessel imaging studies straight, just please watch the cerebrovascular anatomy talk on this channel. And that's your clinical consult for today. Thank you for joining me, and we'll talk again soon. Bye.